Hello, my name is Dr. Kristen Higgins, and I'm a radiation oncologist at Winship Cancer Institute of Emory University, specializing in thoracic malignancies. So what is the role of prophylactic cranial irradiation in small cell lung cancer? So first, just broadly speaking, PCI came into use for the treatment of small cell lung cancer several decades ago. And the reason being was that there was a tropism for brain metastasis in small cell lung cancer. Upwards of 60 to 70% of patients with small cell would eventually develop brain metastasis at some point within their disease course. And that was a real problem, and there were there's limited systemic therapy efficacy in the brain. So studies were performed looking at giving radiation to prevent future brain metastasis, and then the term PCI was therefore coined. Typically, the dose of radiation for PCI is lower than what you would give for whole brain radiation in a patient with known brain metastasis. The standard dose for PCI is 25 gray given in 10 fractions, compared with a dose of 30 gray given in 10 fractions for patients with known brain metastasis. Now, PCI was first developed really before MRI was standard in assessing patients for brain metastasis. And the studies that showed a benefit to PCI several decades ago, patients would enter a study with a CT scan to see if there was any disease in the brain. And it was found that certainly PCI reduced the risk of developing brain metastasis in the future and also improved survival, particularly in limited stage small cell lung cancer. Taking the data together in limited stage disease, PCI yields about a 5% improvement in overall survival. And it still does remain the standard of care in patients that do not progress after concurrent chemoradiation in limited stage small cell lung cancer. Because again, you're going for a cure in those patient populations. So, we will sort of take the potential side effects that would come with PCI. And PCI has been standard for limited stage small cell lung cancer for many, many years. Now, the controversy began to come in over the last decade or so as we started to look at PCI in patients with extensive stage small cell lung cancer. Now, there was a large trial in Europe conducted by the EORTC that looked at giving PCI after chemotherapy for patients with extensive stage disease. And that trial showed that the PCI did improve survival. However, the caveat there was that MRI was not used to assess for the presence of brain metastasis before patients entered the trial or in the follow-up phase of the trials. So, the applicability of that trial to our patients in the United States was somewhat in question because we've been using MRIs to stage the brain for many, many years. And we know that the sensitivity is greater with MRI. And the thought was, well, perhaps, if you entered the trial with just a CT of your brain, maybe you're just treating brain mets earlier, and that's what's giving you this survival benefit. And so there was this trial, another large trial performed in Japan that compared PCI versus MR surveillance of the brain in patients with extensive stage disease. And patients entered the trial with a baseline MRI to make sure that there was no presence of occult brain metastasis before trial therapy started. And then in the patients that were in the surveillance arm, they got an MRI every 3 months. And then patients got PCI and continued to be surveilled with MRI thereafter. And what the trial showed was that there was no survival difference in patients that got PCI versus the MR surveillance. Now, of course, once brain metastases were detected by MRI, the patients then went on to get the therapy that the physician would have recommended. So they were getting their brain metastases treated quickly. And I think that trial really has led to a discontinuation of PCI for extensive stage small cell lung cancer in the United States. There's survey data from radiation oncologists that indicates the vast majority of radiation oncologists in both academic and community practices have really switched their recommendations for PCI and extensive stage disease, and now do not recommend PCI, whereas before the Japanese trial was published, they were recommending PCI. So there's been a big paradigm shift, I think, in the use of PCI in patients with extensive stage small cell lung cancer. And the main reason that that doctors don't want to give this PCI is because of side effects. We see a lot of fatigue and also long-term cognitive changes in patients after PCI that can mimic the side effects of, or really the effects of normal aging, but sort of in an accelerated fashion. And that can be really difficult for patients who are also potentially dealing with cognitive side effects of chemotherapy at the same time. And in many of these patients that may not live very long, we really don't want to reduce quality of life and cause cognitive side effects when it doesn't impact survival. And that is really, I think, the main reason that we're seeing this paradigm shift in terms of the usage of PCI for extensive stage small cell lung cancer. Now, I mentioned the trial that led to discontinuation for most radiation oncologists recommending PCI in the United States. That was based off of a Japanese trial. Now there is a trial very similar that is being conducted right now in the United States called the Maverick trial. And that's a trial within the National Clinical Trials Network run by SWOG. And it's similar to the Japanese trial in that they're assessing MR surveillance versus PCI, but they're including limited and extensive stage patients. So we will actually have a good answer as to whether or not omission of PCI can be used in limited stage patients, because there's really no data for that right now. So I look forward to seeing that trial completed. Patients in that trial are stratified by limited versus extensive stage, as well as use of immunotherapy, as there may be some impact on development of intracranial disease with immunotherapy also. So I think that that's something that we can look forward to as oncologists to further help us when we're making those decisions in terms of who should get PCI and who benefits from PCI. Another potential way to abrogate the side effects of PCI is to avoid giving radiation to certain anatomic regions of the brain that are responsible, for example, for the formation of new memories. There is a technique called hippocampal avoidance that's been employed in patients with known brain metastasis and non-small cell lung cancer. And what it is you essentially pull the dose out of the hippocampus, which is located in the temporal lobes of the brain. And there's a study, like I said, in non-small cell lung cancer that shows if you do that with the whole brain radiation, then it really does reduce the cognitive side effects. There's a trial right now that is using that same approach in patients with small cell lung cancer that are getting PCI. And this is NRG Oncology CC003. And in this trial, patients with limited and extensive stage small cell lung cancer are randomized to standard PCI or PCI with hippocampal avoidance. This trial has almost met its accrual goals, and we should have an answer as to whether or not hippocampal avoidance reduces cognitive side effects in the PCI setting, I think hopefully within the next few years.